experts in urticaria. It's our job to take the guidelines, bring them to our colleagues, explain them with the aim of providing the best treatment, the best management to all patients. Let's start with the first one.
Let's start with the first recommendation, the classification.
Yeah.
What is the meaning of this classification, and why is the classification as it is?
Well, I think this one is pretty straightforward. No, the classification says there's chronic urticaria, more than 6 weeks, and acute urticaria. And what's maybe most important is that in chronic urticaria there are two different types: chronic spontaneous urticaria and chronic inducible urticaria. So we focus on chronic urticaria also because, acute urticaria goes away by itself, or it becomes chronic urticaria, and that's where we have problems, where everyone has problems, and where we need good recommendations on how to treat these patients. So the classification, I think, is very straightforward. I think it's important that we moved away from chronic idiopathic urticaria to chronic spontaneous and chronic inducible urticaria. We have a list of instruments to measure disease activity and impact of disease, control of disease. We decided that we would use the Urticaria Activity Score as the standard instrument to measure disease activity in chronic spontaneous urticaria.
How can you be sure that the Urticaria Activity Score and the Chronic Urticaria Quality of Life questionnaire are the best tools to measure disease activity and impairment of quality of life?
Well, both tools, the Urticaria Activity Score and the QQOL, Chronic Urticaria Quality of Life Questionnaire, have been validated, analyzed, validated, and reproduced. So we know that they really measure the things that they say they measure. And that's what we need. We need validated tools that work everywhere, in all countries, in all patients, in all settings, at all times.
Why do we need it? Why should we measure disease activity? Most patients know if they feel bad, they know their disease is very active. Why do you like to know it in numbers?
Well, I think it helps to compare not only patients, but also different times in the same patient. Because when patients come to us for treatment, they expect that things will get better. How do we measure that? We need to know if things are getting better, so we need a score or a system or an instrument. Because yes, we can ask patients when they come back and they tried a new treatment, did you get better? But that's not a very reproducible answer that we will get. So with the Urticaria Activity Score, patients and we have a chance to really put a number to the disease activity, and when we do it again the next time, see if things got better because of the treatment, see if we're on the right track. Patients have a different view sometimes than the doctor. They see the disease every day, and they can tell us after 6 weeks or 8 weeks or whenever they come back to us if things have changed with the help of this calendar-based, almost diary-based Urticaria Activity Score, where they every day tell us the number of wheals and the intensity of the itch, and we get a number. 42 is the highest number, highest disease activity. 0 is no disease activity, and anywhere in between we can say this is mild, moderate, or severe disease, and we can measure the change.
made the experience when patients come the first time to our clinic, they expect a lot of diagnostic workup in chronic urticaria. What should be our recommendations to the patients?
Well, you know that our recommendations in the guidelines are very simple. There's a two-step procedure. First, we have to make sure that it is urticaria and that there's no severe inflammation. So we take a couple of blood tests and that's it. If we decide to look for underlying causes in chronic spontaneous urticaria patients, then we go by the history, and we do this in patients with long-standing and/or severe disease. And here, a number of diagnostic measures are useful, but it all depends on the individual patient.
So the standard procedure in the majority of the patients is checking for inflammation, for underlying
Correct.
severe diseases, but the focus should be on a sufficient treatment.
That's correct. And treatment in chronic spontaneous urticaria, but also in chronic inducible urticaria, is prevention. Prevention of symptoms. We don't want patients to use the medication we recommend when they have the symptoms. We want them to use the medication to not get the symptoms. And this is very clearly stated in the guidelines. Can be done by preventing the action of mast cell mediators such as histamine, can be done by preventing mast cell activation, by blocking IgE and IgE receptor activation. But whatever we do to help patients is prophylaxis, is prevention, as stated in the recommendations.
I think this is an important point, as many patients in our clinic report that they took their medication in the past on demand. So there's no recommendation to take medication on demand, but rather prophylaxis.
At the beginning, every patient gets a non-sedating, modern, second-generation antihistamine. And if that doesn't work, that first step doesn't work, we go to the second step. And the second step, as you know, is to increase the dose of that second-generation antihistamine. And if that doesn't work, then we move to the third step, Omalizumab, Cilcosporine, Montelukast.
Why it's so important to use non-sedating antihistamines or second-generation antihistamines?
In the guidelines, we decided to talk about second-generation antihistamine. And the reason for this is that most second-generation antihistamines, but not all, are non-sedating. We want patients to take the modern antihistamines that don't make them sleepy.
I found a very interesting study. It's quite old, but I think it's very interesting. It has been shown that after the prescription of sedating antihistamines, the number of crashes, bone fractures, open wounds, burnings is much, much higher than patients who got prescribed non-sedating antihistamines.
That's true, and that's exactly the point. We don't want to cause problems by giving antihistamines. We want to solve problems. And that's what we do with the modern non-sedating second-generation antihistamines.
The recommendation of the guideline says not to mix the antihistamines. Is that important? Or wouldn't two different antihistamines not probably work better than only one?
The guidelines recommend to use one antihistamine and to use more of the same antihistamine if the standard dose doesn't work.
What means updosing?
The guideline recommendation is up to 4 times the standard dose. That means 4 tablets per day, 2 in the mornings, 2 at night. And this can be done differently. It can be done by going from 1 to 2 to 3 to 4 tablets per day, or it can be done by going from 1, if that doesn't work, to 4. If that then works, go down to whatever is as little as possible, as much as necessary. No, that's the principle in dosing antihistamines.
We developed a patient-friendly guideline. I think that's a good way to bring the guidelines to the treating physicians.
These days, we want educated patients. They bring a lot to the treatment, and treatment of urticaria needs the input of patients. The more patients know, the better the management of the disease. So when you say patient-friendly guidelines, I say these are explanations that we provide of the guidelines made for physicians to make patients aware of what doctors are doing, why they're doing it, and on how they can contribute to the management of their disease.